Peace, gratitude, and highest heart love. Thank you for being here for the YouTube live book reading of Poverty, Ethnic Identity, and Healthcare by Vern and Bonnie Bullough. This is it, man. This is the finale. The last chapter. Chapter 9. For the win. Master number 9. Improving healthcare delivery. I'm your moderator and narrator, Uriel NEVEU. Thank you for being on this corner of YouTube where we read books and learn. Chapter 9. Improving healthcare delivery. Today's world is radically changed from that of the part yet American society, in spite of its American medicine, in spite of its tremendous advances, often seems to act as if the United States were still primarily a nation of small towns and rural farms. Over the past century, millions of people have moved from the country to the large urban complexes until today. Less than 5% of the population is engaged in agriculture. In the rural environment, a man within limits could be self-reliant, making his own clothes, growing his own crops, and when calamity threatened, his neighbors or family were usually there to help. Medically, he could learn to know and love a physician who, in time of crisis, often spent long hours with him. If it was necessary to hire a nurse, she came to the patient's house and cared for him on a one-to-one basis. In the city, on the other hand, almost everything a person does is dependent upon the impersonal activities of large numbers of other people, as the city is preeminently the home of the specialists. Such a simple task as getting to work takes the coordinated efforts of dozens of people, whether one takes a subway, a bus, or drives his own car. In healthcare, the individual has been replaced by a team of specialists who individually often do not know what the others are doing. At best, the system is often confusing, and all too frequently it breaks down. An example of the difficulties was outlined by Dr. Milton Romer, professor of public health at UCLA, in his testimony before the Senate Subcommittee on the Health of the Elderly in 1967. May I take the time of a distinguished committee of the U.S. Senate to tell of one aged patient who, like most old people, suffered from multiple diagnoses. He had a serious eye problem, actually two diseases, glaucoma and keratitis, for which he received care at a nearby medical center in the Department of Ophthalmology. His personal doctor, a good internist, however, had diagnosed a mild diabetes, and for this periodic visit were necessary to an office 8 miles away. Painful corns and bunions, impairing the ability to walk, were not within the specialty of the personal doctor, so these required periodic visits to a podiatrist at an office 6 miles in another direction. Dental care, in an effort to save the few remaining teeth, so that dentures would fit more firmly and food could be more properly chewed, required numerous visits to a dentist at still another direction. Then a bladder problem developed and prosthetic disease was suspected. At about the same period, the patient showed lethargy and confusion, suggesting a mild cerebrovascular accident. The personal doctor made a home call, and the decision was to hospitalize. A bed was not immediately available, except in a small proprietary hospital, which the family refused, and it was still 10 days later that he could be admitted to a good voluntary general hospital 15 miles away. After x rays, cytoscopy, and other examinations, there his treatment was stabilized. In the workup, it was discovered that a drug the ophthalmologist had been prescribing for many months was causing serious side effects, which had been missed by the internist since these two specialties had never communicated with each other. Specialists had never communicated with each other. The patient was then admitted to a sanitarium selected for its closeness to the family home, so that the visits from the patient's children would be possibly daily. This was one of the better nursing homes. It was certainly expensive enough at $32 a day paid by Medicare. But this was evidently not costly enough to support a proper staff. After a few days, because of the lack of proper surveillance, this aged patient was found roaming on the street. When this happened a second time, the commercial proprietor decided to discharge the patient as too difficult to care for. It took 5 weeks of nursing care at home with daily problems of incontinence of urine and feces before a bed in another nursing home became available. The later facility proved to be better managed, and the patient improved. After only 2 weeks, however, he was getting up from a chair one day when he fell and fractured his left hip bone. This required an orthopedic surgeon, readmission to the hospital, and preparation for a major operation. But then complications to the diabetes set in because of the traumatic shock of the fracture. Mhm. A delay in over 24 hours in reporting a critical laboratory test nearly cost the patient's life at this time. Had the hospital been adequately staffed, this delay would not have occurred. A skillful operation with a pinning of the broken bone was done. Special duty nurses costing $111 a day over the and above the Medicare coverage of the hospital bill had to be hired because of the shortage of regular hospital nurses. I have not recounted the other details of multiple drug prescriptions, special services of an appliance shop to adjust the bed at home, the physical therapy required for knee injury, and much more. That's the notes. Wow, from the congressional hearing. Dr. Romer added that the patient in question was his widowed father, who had retired after 51 years of medical practice. If Dr. Romer, with his medical background and knowledge, found it difficult to wend his way through the maze of specialists in securing adequate medical care, it should be evident that those with much less ability to deal with the medical establishment would have even greater difficulties. Urbanization, with its great potential for specialization, has encouraged a jungle of specialists and an impossible medical care delivery system. Tied in with urbanization has been the growth of technology, which has made human labor less important as machines have taken over more of the functions once reserved for brains and muscles. This has meant that many types of work have been upgraded so that the average worker now has to have more skills or be better educated than he did in the past. In the case of medicine, this trend has led to a proliferation of devices and techniques, higher educational standards, and greater gaps between the various levels of health practitioners. Not too long ago, most medical care was in the hands of the physician, a nurse, or a pharmacist, but now there are some 35 major categories of jobs within the healthcare industry, which in terms of total manpower is the third largest industry in the United States and one of the most rapidly growing segments of the economy. Welcome all. Thank you for being here. Awesome. Yay. Peace, peace. Much love. We're reading from Poverty, Ethnic Identity, and Healthcare. And this is the last chapter, chapter 9. So, welcome for being here. You guys that are catching up on the other readings, this is the last one for the year and finishing up the book. You see how it works? We got the new moon. Welcome, all, welcome. Much love. Together, technology and urbanization have tended to widen the gap between the haves and have-nots in all societies. In the United States, many of the have-nots are members of groups which traditionally have been discriminated against in America life, and their immediate situation is likely to worsen before it improves. In fact, the hardest hit by the changing employment standards have been the undereducated, particularly members of minority groups, who, in spite of the civil rights legislation of the last 2 decades, often find themselves still at disadvantage because of past economic and educational discrimination. This means that the healthcare, more than ever before, is inevitably tied in with the economic conditions of mass numbers of people. Over the past century, Americans have taken steps to lessen the economic extremes through the enactment of the graduated income tax, the inauguration of a system of social security, and the establishment of various kinds of government supported welfare programs. Medically, we have enacted Medicare and Medicaid as supplements to Social Security, as well as various smaller scale programs aimed at certain groups of people or specific disease entities. However, most healthcare is still privately paid for on a fee for service or insurance basis. This means that people who do not have money to buy good health care are not likely to get it at all. Nearly 200 years ago, Thomas Malthus, an English clergyman, wrote an essay on the principle of population in which he said, I believe it has been generally remarked by those who have attended to bills of mortality that of number of children who die annually, much too great a proportion belongs to those who may be supposed unable to give their offspring proper food and attention, exposed as they are occasionally to severe distress and confined perhaps to unwholesome habitations and hard labor. In 1966, Alonzo Yerby could quote Malthus as summarizing contemporary conditions in America and described the medical care of the poor as piecemeal, poorly organized, and without compassion or concern for the dignity of the individual. The Gordian knot, top of page 170. Thank you guys for being here. I really appreciate you for doing that. Another book clearing. Here we go. The Gordian knot. There are no easy answers to our current health deficiencies. Problems are intertwined and interrelated until there is almost a Gordian knot, impossible to unravel except as Alexander the Great did, by cutting it with a sword and starting over. Although we are not advocating a revolution, it does seem obvious that a dramatic revision of the healthcare delivery system is needed to replace the present complex, patchwork, non-system with a comprehensive and accessible plan for the delivery of healthcare to all the people. However, even with a rational system of healthcare, there will still be inequities in health until problems of discrimination and poverty are solved. As was indicated in the previous chapter, a concentrated effort to eliminate the barriers due to segregation and discrimination in healthcare institutions is still needed. The schools which prepare health professionals should open their doors in meaningful ways so that members of minority groups can be better represented in the ranks of their graduates. And health workers at all levels need to examine their own attitudes towards poor and minority patients. There are probably enough laws on the books to deal with these types of discrimination. But existing laws need better enforcement, both at the overt level and on the more subtle personal level. This book is not the place to go into the whole strategy of ending poverty, since our primary emphasis is on health. But health itself, as it has been emphasized before, is dependent on ending poverty. The complexity of dealing with poverty makes us cautious in proposing any one solution. Many investigators advocate a guaranteed annual wage as a means of fighting poverty. Others, the development of WPA like projects to provide jobs. Others, a cut in working hours. And still others, a vast overhand of welfare system. Robert Hellbronner has argued that a good measure of country's greatness is the way in which it treats its sick, its poor, and its deviants. If such a measure is applied on a world basis, it becomes obvious that the United States, in spite of its great power and strength, is overshadowed by large numbers of nations in the world. Heilbronner believes that our relative failure in this regard is due to an American anti-welfare animus, a feeling that those who do not succeed have no one to blame but themselves. This attitude has led to an anesthetizing of America's social conscience that coupled with a profound suspicion of government has caused us to regard poverty with mixed feelings of indifference and impotence. If Heilbronner is right, the Americans are indifferent to social neglect and reluctant to use public authority to deal with it. Then health care will continue to be in a crisis and poverty will grow. In an earlier and more rural day, personal charity could help ease the burdens. But In this day of the urban problems, government action becomes imperative. And fortunately, or unfortunately, even local governments are no longer able to deal with it. In the past, when government has entered into the poverty area, it has mostly been through the city or county, less often through the state, and only rarely through agencies of the federal government itself. The result has been a patchwork of welfare programs which varies from state to state and even locality to locality, with the greatest crisis in the largest urban areas. The political unit least able to deal with the problem because of the present tax structure and distribution of political power. In order to work effectively toward a solution, we have to recognize that poverty and healthcare are national problems. There are still approximately 25.5 million persons in the United States who fall below the poverty lines. Between 1959 to 1969, the number classified at the poverty level had been declining, but in that year it once again began to increase and has continued to do so. In part, the change represented a change in attitudes of administrations from President Johnson to President Nixon, but it has also been a result of the continuing, ongoing technological revolution. The most severe contraction in the job market has been at the unskilled level, which means that the employment has fallen heaviest on the least educated segment of society. Since most of these workers traditionally have lacked the union workers, they have no organized advocates for their position. If poverty is associated with unemployment, and to a large degree it is, then the obvious answer is more employment. But this apparently is much easier said than done. The most concentrated recent effort to eliminate poverty was made by President Lyndon B. Johnson in 1964 when he declared a war on poverty. The opening battle in his war was the passage of the Economic Opportunity Act, which recognized that one of the problems of the long terms of chronically unemployed was a lack of faith in themselves. An alienation from the system. To overcome this, the EOA attempted to encourage maximum feasible participation of the poverty population in solving their own problems. Grants were given to local groups who were willing to try to innovate or grassroots approaches to solving problems related to poverty. The result was a variety of programs, including occupational training, health clinics, neighborhood services, and Head Start nursery schools. Unfortunately, the escalation of the Vietnam War tended to take public attention and government resources away from the war on poverty, and President Nixon decided to phase out most of the EOA programs. In his critique of the war on poverty, Daniel Patrick Moynihan, who served as an advisor to the President Johnson and Nixon, held that the program had been contaminated from the start by too close a relationship to sociologists who held that the alienation of the poverty population was a basic cause of the continued cycle of poverty. This orientation, Moynihan believed, led to the attempt to get the active participation of the poor and, in his opinion, caused its failure. His criticism cannot be dismissed lightly, but it still does not answer the problem of how to overcome alienation. From our point of view, the failure lies more in the somewhat naive expectation that alienation could be ended overnight rather than in the recognition of its existence. While it is true that instead of the poor, the major participants in planning often came to be politicians, social workers, revolutionaries, and even a few opportunists, a surprising number of the genuinely poor became motivated. Unfortunately for public opinion, strife followed as the various groups fought for control of the local poverty money. This is so good. One love. Peace. Happy New Year. We are at the finale and conclusion. So, this is the perfect time, guys. This is the perfect time. If you'd like to donate, go ahead. We are not monetized. So, this is just a providing service. We're reading the book. So, highest heart love and appreciation. Happy New Year, everyone. Probably a more basic difficulty with the program was that it depended on grants to local agencies to finance programs which supposedly would prove their worth and then be picked up by state and local governments on private agencies. These assumptions were simply erroneous. Few state or local governments had the interest or money to pick up on programs, and most private agencies had their hands full with the tasks they were already doing. The dependence on grants also created administrative problems. In theory, the grant system avoids a large bureaucracy and allows for greater individual initiative. In practice, however, innovation depends not only upon those who are applying for awarded for grants, but also upon those who award them. Since the grants were awarded by a bureaucracy, innovation was limited to what the bureaucracy was willing to fund. To their credit, they often looked with favor upon innovative programs, but not always. Moreover, the Office of Economic Opportunity Programs as a whole were wasteful of both time and money. Much of the time, energy, and talent of local OEO officials and the staffs of participating agencies were spent in writing grant proposals. Once funded, much of the actual money went into administrative overhead instead of directly into the project. Still, when all such criticism had been made, there was a surprising amount of success, and many of the programs proved their effectiveness. In the health field, one of the most successful OEO programs was the training of and employment of home health aides and social work assistants, whose origins were in the community being served. In part, such programs were successful because they did the obvious. They offered jobs to the unemployed. But agencies also found that these new employees were extremely valuable because of their ability to understand and interpret both the client's and the agency's points of view. The OEO demonstration health centers, such as the two clinics opened by the Tufts University School of Medicine in Columbia, Point Housing Project in Massachusetts, and in Mound Bayou, Mississippi, or the Multipurpose Health Center in Watts, have been successful in demonstrating that it is possible to give comprehensive health care and that members of the poverty community can be involved in planning and in giving health care. However, such successful projects serve to emphasize that scattered token clinics which give care only to residents of a specified geographical area, are not enough. In fact, they serve as stark reminders that comprehensive care is not available to all poor Americans. Healthcare delivery system. We're at the top of page 174, guys. Yay! We're in the finale, the last book reading. Here we go, 30 minutes in. Let's go. Healthcare delivery system. This country desperately needs to replace its patchwork non-system for financing healthcare with a comprehensive, federally run system of national health insurance. For many years now, the United States has been the only industrialized country which does not have some kind of national health insurance or national health service. Usually, the failure to develop such a system is blamed on the American Medical Association. And although this is a much too simplistic explanation, the AMA has certainly been a significant force in saving us from socialized medicine. For a long time, the organization was in the hands of general practitioners who were fighting against the increasing specialization of medicine. In part, the doctors who were most active in organizational activities were also likely to come from smaller towns, so that in a sense, the 20th century struggle within the AMA represented an alliance of the small towns against the big cities, of rural versus urban, and old American values against the new. Over the years, while the ultra conservative forces held sway, the organization fought against private health insurance, maternal health programs, various aspects of Social Security legislation, medical care for military dependents, and even against Veterans Administration hospitals. The AMA is still a conservative organization, in part because the very nature of medical practice tends to leave the average doctor with little time for organizational activities. This means that the association is usually dominated by the older retired physicians who are still thinking both politically and medically in terms of their own youth. Too often, they assume that medical care is still given on a one-to-one basis with a fee for service, while physicians have generally been noted for their compassion. The heavily science oriented focus of medical education has given them little background with which to understand the problems of the modern world, and their too heavy work schedule has left them little time for independent study. Although the attitudes and actions of the AMA still affect the way in which the medical establishment works today, as will be indicated later, no lobby, and the AMA is a lobby, can be effective unless it expresses the views of large segment of its members, as well as the general population. For a long time, the AMA attitudes were the dominant American ones. But increasingly, nurses, hospital administrators, public health officials, and others have broken with the AMA, while the balance of power within that organization has shifted somewhat to the urban practitioner. The result has been a modification of some of the earlier political positions. There is also a growing number of doctors, usually young ones, who have refused to join the organizations. Some of these rebels have joined with other health workers to form dissident groups such as the Medical Committee for Human Rights or Physicians for Social Responsibility, but large numbers of others remain unorganized as the salary medical positions have helped weaken the power of the AMA because they cannot use denial of hospital positions as a negative sanction to force membership. Other countries, we are doing it. We're at the bottom of page 175. Germany, under Prince Otto von Bismarck, was the first country in the world to establish a compulsory national sickness insurance program. The original program started in 1883, gave free care only to enrolled workers, but benefits were soon extended to the families of employed persons. Following the German example, several other European countries took steps to have their government enter into the medical field, including Austria in 1888, Sweden in 1891, Denmark in 1892, Belgium in 1894, and Switzerland in 1912. England acted much more slowly and in more piecemeal fashion. Some compensation was given to a few workers in 1880, and a limited national health insurance program was enacted in 1911. But complete health coverage was not established until the inauguration of the National Health Insurance in 1948. The Union of Soviet Socialist Republic nationalized all healthcare in 1917 as a part of the Russian Revolution, and other countries which came under the Russian sphere of influence following World War II patented their healthcare delivery system after that of the Russians. There are numerous other countries which have also adopted some form of government sponsored or controlled healthcare. In spite of the fact that the various government sponsored plans are usually labeled socialized medicine by the AMA and its supporters, there is a vast difference in the way each country administers its programs. Some are based on a fee for service, some on cash reimbursement, others on a capitalization basis, others on straight salaries. Each system has its advantages and disadvantages. The difficulty with the negotiated or set fee for service system is that the better paid procedures tend to be more frequently performed than those paid less because of the physician is likely to opt for the more expensive treatment than the lower costing one. I gotta pause right here because this is so key to where we are. Did you just hear what I just read? All these other countries have nationalized healthcare, and we are still not there. And it's 2024, going into 2025. In the United States of America, let's go. This is why y'all wanted to read this book, huh? Just to confirm. Right? We got to let that pause and just sit in there. That's why it's important for us to master ourselves so we don't have to go through these other people. Look, right? Oh, look at that. Thank you. Highest heart, love, gratitude. This is big. So, moreover, failure to pay adequately for certain procedures can result in the underdevelopment of an entire specialty. Fee-for-service benefits the surgical specialties more than the medical or preventative specialties, since the surgical specialties can easily be itemized and priced. In those systems in which any doctor can be paid for any procedure, general practitioners become more alike in the skills and income, and specialties become more versatile, since the narrower the specialization, the more difficult it is to establish a set fee. Fee-for-service systems also enable the physician to bill the funds without the patient's knowledge, since there is little witness to the actual work as against the physician's claims. Under this system, it is possible to write fee schedules with variable payment formulas that discourage the unnecessary multiplication of work. But the problem is to prevent these formulas from discouraging justified long term use. An example of a country where a fee for service is practiced is Germany, Deutschland. Originally, the German system arranged for individuals to join a sickness fund, and this fund then contracted for care from groups of doctors. At the present time, there are about 200 such funds in operation in West Germany, covering about 87% of the population. Within the group of patients can choose their own general practitioner, but are referred to specialists only as needed. Physicians are paid on the basis of a fee for service, with fee levels being negotiated by the sickness funds and the local association of doctors. Hospitals are run by local government and their staffs. Physicians as well as nurses are salaried. Although satisfaction with the system is high, some 90% of those enrolled recently indicated they would remain if it were voluntary instead of compulsory. It is not without problems. In order to get reimbursement, physicians with few patients tend to require more visits per patient than the busy physicians. In a 1966 study, it was found that doctors who saw 2,500 to 3,000 patients per calendar quarter provided 5.06 services per person, while those seeing 1,000 to 1,500 provided 6.24 services, and those seeing fewer than 1,000 provided 8.90. From this, it would seem that at least some of those extra visits to the practitioner with the small patient load may have been motivated by a desire to keep up income. From the physician members, the greatest complaint is the amount of paperwork required to gain reimbursement. From the governmental point of view, the system is expensive to operate unless there is a very rigid fee control. Peace. Thank you. Thank you so much. All right. So there it is. There, from Lewis. Thank you for the $10 donation to the Cash App. Thank you. Much love. Thank you so much. Oh, that's so honorable. Closely allied to the negotiated fee for service system, but with more difficulties and complications in operation, is the cash benefit system. Instead of receiving a fee for his service, the physician charges cash and then the patient is reimbursed. This system has the advantage of being the most politically feasible in those countries where there are well established medical practitioners, such as in the United States. The physicians are usually more willing to accept this reimbursement procedure because they believe that it will preserve the autonomy in full because the patient, not the physician, communicates with the sick fund. When this system has been tried, these beliefs are expressed by the medical profession have been proven wrong because physicians who charge higher rates for the same service soon find themselves being queried by the reimbursement agency, and those who persist find themselves under investigations. Inevitably, many doctors are placed under sanctions by the government, even to the point that patients going to them are not reimbursed. Most cash benefit systems also anticipate that the patient will pay part of the initial charge. But the effect of this is to discourage the poor from ever seeking needed medical care or waiting until an emergency arises. In order to get around this, it has become necessary to impose means tests and the very thing that national health insurance was supposed to eliminate. The cash payment system also has most of the other difficulties of fee for service. Nevertheless, both France and Sweden have established cash benefit systems, which, from the doctor's point of view, have the advantage of giving high incomes to the doctor. Both countries have also achieved better results in medical care for the poor than the United States. Thank you so much. Oh, that's so much love. Much love. Oh, love. Thank you. Thank you. Oh, wow. Darlene, thank you, Darlene. Highest heart love to you. Blessings. Thank you for reading with us. Poverty, ethnic identity, and healthcare. Darlene just sent $40. Oh, she says, thank you. Oh, that's love. I love that y'all love me reading these books, man. That is so much love. Wow. Honor, honor. Capitation, as it is operated in England, is much simpler to administer than fee for service or cash benefit systems. But it also has difficulties. Under the English system, a doctor is responsible for a panel of patients, which means that the quality of his service is dependent upon his own conscience or the informal sanctions of other members of the profession. At worst, the system gives little encouragement for the physician to do more than the minimum required for the patient, but it also discourages unnecessary or drastic medical procedures. If a physician has a time consuming patient, he might want to transfer him to another panel or to an outpatient department of a hospital unless there are effective administrative or ethical deterrents for him not to do so. The English system also reinforces a distinction between the general practitioner and the specialist by depriving the general practitioner of any financial motive to perform tasks assigned to the specialist. It has the merit, from the physician's point of view, of preserving the individual practitioner in his office, and in England and Holland, where the capitation system is most firmly established, general practitioners were traditionally based in private offices, separate from the specialists who were attached to the hospitals. The English system has the advantage of offering almost universal coverage. Each patient is assigned to a panel, and there are similar panels for dental care and drugs. Specialists and hospital employees are on direct salary under the direction of the Ministry of Health. The chief dissatisfaction with the capitation system comes not from patients but from physicians. Many physicians feel their pay is low, and to increase it, they take on rather large patient panels, an average of 2,300 patients. To handle so many patients, they have they then have to work long hours and cannot spend as much time with each patient as careful medical practice would indicate is desirable. The separation of the general practitioner from the patient in the hospital and lack of contact with specialists also reduces the intellectual stimulation of seeing the seriously ill patient or working with colleagues. This is not so much a difficulty with capitation per se, but with the way healthcare delivery is organized in England. Most countries that have national health schemes rely heavily upon salaried physicians, although even here there is great variance in medical care because the delivery system seems to be dependent on past tradition within the country. In many ways, the salary system encourages desirable characteristics such as non mercenary attitudes, close colleague relationships, interest in personal professional growth, and it also has the virtue of greater administration simplicity than the other systems. The salaried system also discourages unnecessary treatment or medically unjustified multiplications of procedures, although in the few systems in which doctors earn overtime or can select the amount of salaried work time, this is a problem. Under a salary system, also medical care can be more equitable, distributed through encouraging medical practitioners to go into areas of greatest need by giving them higher salaries to do so. In salaried systems, which also allow the physician to have a private practice, the more affluent patients are often referred to the individual doctors in the private practice hours, thus subverting the system somewhat. This is particularly true in countries like Egypt, where salaries for physicians are low. Russia and most of those countries which have followed the Russian lead have adopted the salary system. In Russia, all levels of health workers are salaried, and care is given through a system of polyclinics, health centers, and hospitals. In line with earlier Russian tradition, there is considerable opportunity for advancement within the system, and theoretically, a hospital orderly or an ambulance driver can work his way up through a system of additional training programs to become a physician. In actuality, this sort of upward mobility is uncommon, although nurses and fieldshers, the middle level medical workers, occasionally move up the career ladder to become physicians. Soviet doctors give fewer diagnostic tests and treatments than do Western physicians, but this may be due less to the salary than to the clinical tradition, which for a long time suffered from a shortage of equipment, technicians, and laboratories. The Soviet system of medicine is one of the most popular governmental services in the USSR. And even the personal shortages and time pressures of World War II did not lead to dissatisfaction. The Harvard Russian Research Center, for example, interviewed Russian uh, emigres shortly after the war and found a remarkably high level of satisfaction with the doctor patient relationship. Those refugees who eventually settled in America felt that one of the few advantages Russia had over American system was in the medical care delivery system. There are other variations of payment for healthcare delivery, and in fact, many countries have combinations of several, as does the United States today. All of the systems, however, at least in the industrialized nations, tend to offer adequate medical care and have the advantage of reaching segments of the population not reached by the American system. This does not mean that the United States should adopt any of the systems per se, in part because American medicine has a different tradition, but that there are many kinds of variations possible even in the socialized medicine. We're at the middle of page 180. Peace, everyone. Much love. Yes, this is so awesome, right? Wow. And yes, the medical healthcare system saves lives and also can destroy. The struggle for health insurance in the United States. The attempt to gain a national health insurance in this country has been and continues to be a long and bitter struggle. In the process of the struggle, American medicine has developed along certain lines which have to be considered in planning a better healthcare delivery system. In order to understand the importance of this early struggle in forming medical practice today, it is necessary to examine some of the past history of the medical insurance, if only briefly. One of the early leaders in the campaign for government sponsored health insurance was Dr. Alexander Lambert, an AMA leader, who was also personal physician to President Theodore Roosevelt. He had enough influence to get compulsory health insurance included in the platform of the Progressive Party platform in 1912, when Theodore Roosevelt attempted to regain the presidency. It was several decades, however, before the Democrat or Republican parties picked up this part of the Bull Moose or Progressive Party platform. With the failure of the Roosevelt campaign, which of the early efforts to gain some sort of health service was directed by a private reform group called the American Association for Labor Legislation, which had originally been established to lobby for workmen's compensation laws in various states. As this movement succeeded, some 41 states had enacted laws by 1920. The association turned its attention to the health problems in its early attempt to establish health insurance. The AALL, for a brief time, had the support of the AMA, which between 1915 to 1920 was its progressive best under the influence of the leadership of Lambert. I. M. Rubinow and others who were members of an AMA Social Insurance Committee established in 1915. By 1920, However, in part due to grassroots opposition by doctors, the AMA had adopted a policy of official opposition to any kind of health insurance, private or public. The model health insurance bill drawn up by AALL providing for broad hospital and medical coverage to workers and families on a state level was introduced into 20 state legislatures between 1914 and 1920. And some 9 states appointed special commissions to deal with the subject. None of the bills passed, and the movement almost died during the 1920s. Employers were generally antagonistic, on the ground that their costs would be increased. Commercial life insurance companies became active opponents, even though at the time they wrote little health insurance. The AALL plan, however, included a funeral benefit which the insurance companies opposed, and they also had in effect about $6 billion of industrial insurance. Even organized labor, particularly in the person of Samuel Gompers, president of the AFL, opposed the health scheme on the grounds that it would lead to government control of the union movement. Many state federations, however, were in favor, and it was the state labor organizations which gave the greatest support to the effort. Large pharmaceutical houses also opposed the various bills, as did an increasing number of local medical societies and individual doctors whose opposition eventually led the AMA itself to oppose the plan. In California, where the state constitution permitted a referendum, an attempt to set up a state sponsored health insurance plan was overwhelmingly defeated at the polls. The issue was not dead, only dormant. Continuing concern over the cost and organization of medical care by 1925 had resulted in a Washington conference on the economic factors affecting the organization of medicine. A second conference was held in 1926, and this led in 1927 to the formation of a committee on the cost of medical care under the chairmanship of Ray Lyman Wilbur, Secretary of the Interior for the next 5 years. The committee, with the support of various private foundations, investigated the cost of medical care. Its findings and recommendations filled some 28 volumes, and there were a number of subsidiary reports in addition. The final summary, entitled Medical Care for the American People, appeared in 1932 when the country was at the depth of the Depression. It included both a majority and a minority report. The majority favored the medical and hospital insurance on a voluntary basis until adequate experience could be accumulated to serve as a sound basis for a comprehensive system based upon compulsory tax deductions. The majority also approved group medical practice organized around health centers and grants in aid to provide hospitals, doctors, and nurses to poor and thinly populated areas. It also urged government support of the cost of medical care for the indigent, the tubercular, and the mentally ill. The minority, on the other hand, opposed any kind of prepaid medical care, even on a voluntary basis, and vehemently objected to the proposal for group practice. The minority, however, was willing to accept hospital insurance plans provided they were sponsored and controlled by organized medicine. Its view in general coincided with the emerging view of the AMA. The hostility with which the majority report was greeted by the medical profession is evident from the pages of the Journal of American Medical Association, which labeled it as inciting to revolution. The words of the then editor of the journal, Dr. Morris Fishbane, indicate better than any other statement we could make the racist and anti-government attitude so characteristic of organized medicine at the time. Here is the quote. One must review the expenditure of almost $1 million by the committee and its final report with mingled amusement and regret. A colored boy spent $1 taking 20 rides on the merry-go-round. When he got off, his mammy said, "Boy, you spent your money, but where you been?" This Fishbane felt was the same as the committee's efforts. He even went so far as to call the recommendation for group practice an attempt to establish medical Soviets. Awesome! In spite of such vehement opposition, national health insurance became a major issue during the early years of President Franklin D. Roosevelt's administration. The Depression, with its resulting desperation, once again created a climate of opinion favorable to social legislation. Many physicians found themselves with rapidly declining incomes and were unable to collect from their out of work patients. This helped change their attitudes, at least temporarily. In 1933, Congress, with AMA approval, appropriated money to help pay doctors' fees. This temporary measure was soon found to be inadequate. To deal more effectively with this and other problems, President Roosevelt in 1934 appointed a cabinet level committee on economic security under the chairmanship of Frances Perkins, Secretary of Labor. Mrs. Perkins immediately announced that she favored enacting into law sustainability of all the social insurance measures which European countries earlier had set up. Harry Hopkins, who held various jobs under Roosevelt and acted as his close advisor, was also in favor of health insurance. The omens seemed favorable, but by the time the committee completed its report, the AMA had once again announced its opposition to health insurance. Fearful that medical opposition would prevent the passage of any Social Security legislation, Roosevelt requested the House Ways and Means Committee to strike most provisions dealing with medical care from the bill establishing Social Security. With these deletions, Social Security was enacted into law. Token concessions to health insurance supporters was given in the form of increased grants in aid to states for maternal and infant preventative care and a strengthened public health program. And both of these measures were passed over the opposition of the AMA. The extent to which organized medicine was prepared to go was demonstrated by the case of the Milbank Fund, set up by Albert G. Milbank, chairman of the Borden Company. The Milbank Fund had granted money for local studies of preventive medicine, and its secretary, John A. Kingsbury, had criticized the AMA for its opposition to the then pending Social Security bill. A member of medical journals began hinting through editorials that a boycott of Borden products would have been a salutary effect on the fund. Not surprisingly, doctors' recommendations of Borden's irradiated, evaporated milk for babies fell off, and so did company profits. Milbank was led to deny his fund and had ever endorsed compulsory health insurance or any other plan to distribute the cost of medical care. Shortly afterwards, Kingsbury lost his post as secretary of the fund. In spite of such actions, the leaders of the AMA realized there was a growing demand for some kind of health insurance. To head off any government sponsored plan, they reversed their opposition to voluntary insurance plans. The first to gain support were the hospital plans, particularly the Blue Cross, which had its origin at Baylor University in Texas in 1929. By 1935, hospitals had enrolled some 23,000 people in more than 400 different employee groups. In 1933, the American Hospital Association's Board of Trustees approved the principle of hospital insurance as a practical solution to the more equitable distribution of the cost of hospital care. The American College of Surgeons, whose members were dependent upon hospitals, endorsed a similar scheme in spite of AMA opposition. By 1937, the American Hospital Association had taken to approving various hospital plans which met its criteria by allowing such plans to use its trademark of the Blue Cross. In the first list of Blue Cross subscribers published in 1938, some 1.5 million people were enrolled. By 1953, some 41.8 million persons were enrolled in Blue Cross plans. We're in the middle of page 184. Isn't this so good? We get to track it all the way back, right? This is powerful. What an amazing read. Thank you for reading with us. We're on that corner of YouTube where we read books, learn, honor each other. This is that love life. That's what I call it, the love life. Hospital insurance was one thing, prepaid medical care was quite another. Here, the opposition of the AMA was much more vigorous. The matter came to a head in the case of the Group Health Association established in 1937 in Washington, D.C. by employees of the Federal Homeowners Loan Corporation. This nonprofit prepayment hospitalization and medical care program contracted with physicians to serve its members. The doctors employed by the group soon found themselves expelled from the District of Columbia Medical Society and barred from the 7 district hospitals because of their lack of AMA certifications. The District Medical Society even went so far as to warn physicians of a rule barring medical consultations with non-society members. Hospitals were also warned that if they accepted patients from the group, they would lose the AMA approval for their intern training programs. The effect of such action was to deny hospitalization to members of the group health association. Because of these and other criminal actions against the health group, the United States government instituted a suit for criminal violation against the American Medical Association and the District of Columbia Medical Society. The resulting conviction was eventually affirmed by the United States Supreme Court in 1943. In the meantime, to head off any similar plans, the AMA set up a Council of Medical Service and public relations designed to encourage state medical societies to make some type of health insurance plans available to the public, something which several state medical societies had already initiated. To coordinate these plans, Associated Medical Care Plans was created in 1945 and adopted the Blue Shield as its copyrighted symbol. Look at that. You see where we're going? We just talked about the AMA with the Blue Cross. And now we hear to coordinate these plans. Associated Medical Care Plans was created in 1945 and adopted the Blue Shield as its copyrighted symbol. What? We just have read and put together how we got to Blue Cross and Blue Shield. Bing. Medicare. We're at the top of page 185 in the conclusion of this reading. Well, we got a few more pages left. Medicare. The goal of a national health insurance was still a lingering dream, at least to some. In 1939, a national health proposal was finally introduced into the United States Senate by Robert F. Wagner of New York. It failed to get out of committee, but Wagner continued to introduce it in successive sessions. In 1943, he was joined by Senator James Murray and Representative John Dingell, and in this and subsequent years, it was known as the Wagner-Murray-Dingell Bill. In spite of public opinion polls indicating strong national support for governmentally sponsored health insurance, the AMA and its allies were able to prevent the bill from coming to vote. After repeated failures to secure a vote, health reformers decided to concentrate on a lesser goal: health benefits for Social Security beneficiaries and health benefits for Social Security beneficiaries. This concept had great appeal because the financial drain of serious illness was the most devastating for the elderly and for the welfare recipient, and it was these groups which were the least likely to be covered by voluntary insurance plans. Moreover, the growing percentage and numbers of the elderly in the population represented a politically potent interest group. In 1957, Congressman Amy J. Foran of Rhode Island introduced a bill to furnish hospital, surgical, and nursing benefits to all Social Security beneficiaries. Opposition sprang almost immediately from the AMA, the National Chamber of Commerce, the National Association of Manufacturers, the Health Insurance Association, the Pharmaceutical Association, and the American Farm Bureau Federation. Support came from organized labor, from the National Association of Social Workers, the National Farmers Union, and most importantly, the American Nurses Association. The nurses' support was important because it indicated that a significant number of health professionals were opposed to the AMA stand. The support of the nurses was also a factor in encouraging the American Hospital Association to reevaluate its position on health insurance. Though the AHA did not at this time come out in support, it did not oppose the bill, and the association took the opportunity to point out that something had to be done to help elderly patients pay their bills, if only because so many hospitals were being left with uncollectible debts. In 1960, Senator Robert Kerr of Oklahoma and Congressman Wilbur Mills of Arkansas introduced a substitute bill providing for federal subsidies to states in order to help pay for the health care of welfare recipients, including aged indigents. Though this was a weak compromise for the foreign bill, it had the merit of being enacted. The new legislation soon proved to be ineffective because many states never bothered to institute the programs necessary to utilize the grants. In 1962, the Medicare bill, a revision of the original foreign bill, was again introduced, but this time it had the full support of the president, John F. Kennedy. Although it failed to get out of the committee in the session of Congress, it gathered support and was enacted into law in 1965 under President Lyndon B. Johnson. Financed through the Social Security system, Medicare provides two separate but coordinated coverages: hospital insurance for most persons age 65 or over, and supplemental medical insurance for those persons in the same age group who voluntarily enroll and pay the required monthly premiums. Although the patients are required to pay a portion of their hospital bill, the coverage is substantial. A companion bill upgrading the provisions of the Kerr-Mills bill were was also passed in that year and is generally known under the term Medicaid, although various states call it by different terms. It gave funds to states to set up health care programs for welfare recipients covered under the federal programs for families with needy children, the total, the totally or partially blind, and the totally disabled. In order to cut down medical opposition and that of the insurance lobby, Medicare was administered through voluntary insurance carriers, usually Blue Cross. More troublesome was the fact that little control was put over the fees. And one of the immediate results of the passage of Medicare and Medicaid was the escalation of doctors' fees, something which was predicted by almost everyone who had ever studied Medicare delivery systems. Hospital costs also skyrocketed. Although the connection of these increases to the legislation is due more to past practices than any new ones. The health industry has never been a particularly efficient one, and the lack of government controls did little to encourage economy. Thank you all for being here. Oh, this is so good. Oh, wow. Oh, he said my articulation is exquisite. Oh, much love. I appreciate your words. Highest heart love. The current situation. We're at the top of page 187. In spite of these improvements in the medical care delivery system, healthcare remains in a crisis simply because it still is not organized to meet the needs of today. In fact, the very opposition of the organized medical profession to the past health schemes has so changed American medicine that programs such as Medicare, which fail to take these changes into account, are bound to be in difficulty. The reluctancy of physicians to accept medical insurance led more and more to of the medical plans to concentrate upon hospital insurance. Most such hospital plans were made on a cost plus basis, which meant that hospitals were free to expand or buy new equipment to meet needs, both anticipated and hoped for. Hospitals were able to do this because the cost, almost any cost, in fact, would be automatically covered by insurance. Moreover, the opposition of physicians to health insurance led more and more medical activities to be put into the hospital in order to gain reimbursement for the patient. And in the process, the physician became more and more dependent upon the hospital. Activities which in an earlier period were carried out in the physician's office now were done in the hospital in order for the patient to be reimbursed for his expenditures. Hospitals became a place not only for the sick or injured, but for the patients undergoing diagnostic work, as the doctor knew the only way the patient could have his insurance company pay was to put him into a hospital. Now, see, this is so key, guys. Can you feel this? This is part of the major problem, the current situation, what we're reading right now. See, to get, I'm telling you, because I'm explaining just briefly how this works. So, with the health insurance, they're saying instead of getting paid right from the patient, the insurance has to get billed from the hospital to cover the cost of the patient. And then the patient pays a little portion of the bill through the health insurance. And that covers everything entirely through what we are talking about now, Medicare. Okay. So basically, what we're talking about in here is the section and area in American society where people were saying, no, I want to get paid for my services now. And then there's other section that's saying, well, I understand the patient can't afford it, but their health insurance can afford it. So they're going to pay a little portion, and then I have to bill the insurance. And what makes them get the bill? So they used to come right to the doctor. Now they have to go to the hospital and get the procedure. Then the hospital bills the insurance so that the practitioner can get paid. You see that? It may make sense to some of us, but to the normal person, it doesn't make any sense. All they know is they need help. right? All they know is that they need help. Bottom of page 187. At the same time, the nature of the medical education in the United States changed, mainly because the federal government poured billions of dollars into biomedical research. In fact, so much money was available that the central activity of the country's major medical schools changed from teaching medical students to carrying out medical research. This not only tremendously increased the cost of the medical education, both to the individual and to the taxpayer, but in the process, it also erected an ever escalating ladder of medical costs. For example, during the 10-year period from 1959 to 1969, the budget for the Stanford University School of Medicine rose from 5.5 million to 25.5 million without any basic increase in the number of students being graduated. During the same period, the federal grants rose from 2.3 million to 15 million, or from 41 to 60% of the budget. Yet the total cost to Stanford, to its students, and to its patients also rose. The bulk of this increase went not to patient care, but to research. Until in 1970, Stanford had 375 full-time faculty members and only 357 medical students. It also had several hundred part-time faculty members who came in occasionally for consultation or who maintained a university connection for prestige reasons. The availability of federal funds for medical research had created new glamour positions in medicine for the university medical professors. In the process, university affiliations has also become a matter of great importance to hospitals who want to attract interns and residents for their ongoing medical care. In New York City, for example, over the past 2 decades, almost all the hospitals and health centers have affiliated with one of the city's 7 medical schools. In Baltimore, Johns Hopkins Medical College, and in Boston, Harvard, are the medical centers for which affiliations radiate out to nearby hospitals. The resulting medical empire networks of affiliated institutions are replacing the individual hospital as the basic unit of practice, just as hospitals earlier replaced the private doctor's office. Increasingly, also, major medical institutions have begun to display an internal dynamic of their own, expanding to larger and larger proportions through more and more affiliations in order to maintain their status and their prestige. In the process of building these medical empires, however, the whole nature of patient care has been downgraded because the rewards come from other directions. The result has been with what some have called a medical industrial complex. In 1969, Americans spent more than $60 billion on medical care, which represented an 11% increase over the previous year and double the amount spent in 1960. The 1969 expenditure amounted to 6.7% of the gross national product, which is almost double the percentage spent in other industrialized countries. The health industry is big business. And despite the fact that much of its claims to be nonprofit, it reported some 2.5 billion in after-tax profits. The implications for healthcare become obvious. Community hospitals, for instance, spent 16% more money in 1968 than in 1967, but provided only 3.3% more days of inpatient care and 3.7% more outpatient visits. While some of the increase went for wages, most of it went to pay the inflated cost of drugs, supplies, and equipment, and in many cases to profits for doctors and to the hospitals. Much of the equipment which was purchased had a planned obsolescence, and in many of the smaller hospitals, such equipment, particularly of the electronic variety, largely went unused. A high proportion of new building went for research facilities rather than to those devoted to patient care. Inevitably, the cost of medical care has increased. In 1950, the nation spent 3.8 billion on hospital care. By 1965, the figure had risen to 13.8 billion, and in 1969, 3 years after Medicare and Medicaid, expenditures for hospital care alone were running at 20 billion a year. Without materially serving a larger number of patients, county hospitals have also found their costs mounting. The city of Chicago, for example, has seen public expenditures of and for healthcare go up fourfold between 1960 and 1970, from 100 million to 400 million dollars. But there is still a major crisis of unmet needs. In 1970, it cost $104 a day just to keep a patient in Cook County Hospital. Bottom of page 189. Extension of government supported healthcare. Extension of government supported medical care. The escalating crisis in medical care has led an increasing number of people publicly to advocate some form of national health insurance. So great is the need, in fact, that most experts are predicting the enactment of some sort of comprehensive medical care program within the decade. Although a single well thought out health care package might be the ideal way of solving the growing problems, politically realities political realities would indicate that reform is more likely to come about in a piecemeal fashion. From this perspective, the 1965 Medicare and Medicaid legislation can be viewed as opening wedges in the gradual reform process. The difficulty with the piecemeal system, however, is that long range goals are too often neglected, and for any system to be effective, no matter how it is enacted, it is essential that long range goals be established. In our minds, one of the most important long range objectives should be the establishment of a comprehensive healthcare system, something which is now almost totally lacking in American medicine. This was not true so much in the past, but in recent decades, the patchwork financing systems and the growing trend toward specialization in medicine have created a fragmentation of care. Though poor people and minorities can now receive a certain amount of health care, the value of the care is not so great as it could be because of fragmentations. The federal government, for example, furnishes care through various agencies, not to many people, including the aged, the blind, the totally disabled, families with dependent children, veterans, and members of the armed forces. As we have indicated, research hospitals sometimes give outstanding care to a patient with a rare disease or someone who fits into a given study sample, but other seriously ill patients are ignored. Private funds sometimes finance the care of a specific disease, but often these specialized agencies or hospitals are located far from the point of need. Health departments give preventative care to mothers and infants, but usually do not give acute care. This maze of eligibility categories is difficult enough for the experts to comprehend, but it is truly formidable for the poor, the uneducated, and those with a language barrier. Moreover, even when services are available in scattered specialty facilities, someone with multiple hair health problems often must travel around to various specialists because there is no one worker who looks at the total health problem of the patient or evaluates the total regimen. This is true in private patient care as well as in charitable or governmental medical care. An effective plan to deal with healthcare has to do away with the complex eligibility rules and simply give healthcare to all of the people, employed or unemployed, rich or poor, citizen or alien, young or old. Healthcare, in effect, has to be conceptualized as a right for all instead of a privilege for those who have money or accidentally qualify under some special program. We also need to establish some means by which one worker can take primary responsibility for coordinating the patient's care. In the past, this was the role of the general practitioner. But because of the trend in medical education away from producing family doctors and toward gathering ever more specialized knowledge, it is possible that the primary care role will fall to a less expensive worker, such as the nurse practitioner or the physician's assistant. This worker, whether he be a general practitioner, nurse practitioner, or physician's assistant, should be allowed to treat the less complex illnesses and refer the problems to the various specialists. He should also coordinate the care so that the welfare of the total patient is not overlooked as the specialists narrow focus on disease and organs. Ace, and we have this now. You see this, with your general practitioner, um, doctor, and then your specialist. So we've picked up from there, right? A second important goal in the establishment of a plan for healthcare is for the system to be economically feasible. This means that the already existing Medicare, Medicaid legislation increase costs, but not necessarily improved medical care. Peace, everyone. Thank you so much for the finale. We're at the finale of poverty, health, ethnic identity, and healthcare. This means that the already existing Medicare and Medicaid legislation needs revision to cut out its inflationary characteristics that have increased costs but not necessarily improved medical care. Fee controls and cost accounting procedures are badly needed, and the unnecessary administrative costs of using intermediate carriers, such as Blue Cross, to do the work for the government can do cheaper itself, should be eliminated. Planning for economy is always a difficult aspect or reform because each of the various lobbies works to see that its group gains economic advantages. But it is a crucial step in order to make a health plan workable in the long run. Both of these major objectives, that of making healthcare comprehensive and making it economically efficient, can, in our minds, best be furthered by the encouragement of government sponsored health maintenance organizations. Basically, these organizations are a form of group practice, something pioneered by Americans. The first group practice was the famed Mayo Clinic in Rochester, Minnesota, in which the various professional and paraprofessional groups worked together to treat the patient. The Mayo Clinic, which dates from the 19th century, was originally developed not for preventative reasons but to deal with the seriously ill patient. Its example has been followed by various other specialized clinics, such as the Cleveland Clinic or the Ochsner Clinic in New Orleans and the Leahy Clinic in Boston. The constitution of the experts assembled in these clinics probably furnishes the best medical care in the world. These clinics had little opposition from organized medicine, but when the concept of the clinic was combined with the prepaid factor and opened up to a wider public, organized medicine went into opposition. In fact, many states, on the urging of their medical associations, passed laws prohibiting group practice of any kind, and such laws still exist in several states. The two best known of the prepaid group practice insurance plans are the Health Insurance Plan, HIP, in New York, and Kaiser Permanente on the West Coast. Both have the advantage of adjusting to realities of the way in which the best medicine is increasingly practiced in this country, and they have the additional advantage of costing less than other insurance plans. Kaiser Permanente was started by Henry J. Kaiser, the California contractor, of a plan for his employees when he was building Grand Coulee Dam. It was expanded during the World War II as he turned to building ships, and then further expanded as the industrialists turned to manufacturing steel, aluminum, and automobiles. Shortly after the end of the war, the system went public, and through contracts with various unisons and other organizations, Kaiser Permanente began offering total prepaid medical care to all subscribers. For those who belong to the more complete Kaiser plans, everything is paid except for drugs used in outpatient care, and these are sold at less than wholesale prices. From the first, Kaiser Permanente has insisted that all companies and organizations offering their plan also offer competing ones. This has tended to keep subscribers from feeling trapped within the Kaiser system, and it also served as an effective cost accounting procedure. The great virtue of the Kaiser system and that of similar ones is that they emphasize preventative medicine. The difference that effective preventative care makes was demonstrated by a study of federal employees on the West Coast, some of whom were insured by Kaiser Permanente and other by Blue Cross Blue Shield. The study found that although Kaiser subscribers had greater contact with physicians and other health practitioners, they spent far less time in the hospital. Each unit of 1,000 federal employees spent a total of 433 days in the hospital per year under the Kaiser plan, while those under Blue Cross Blue Shield spent an average of 865 days per 1,000 employees. This enabled Kaiser to keep its costs some 20% lower than in California's voluntary hospitals, and to keep the rate of increase to less than half of the national rate. Prepaid group plans achieve these lower costs by practicing effective preventative medicine and cutting out unnecessary operations or other medical procedures. Kaiser's surgery rates, for example, were little more than one half of Blue Cross figures. As one Kaiser official stated, Kaiser has a vested interest in keeping the patient well. A few pennies spent on prevention saves dollars spent on the cure. And we've heard that plenty now, right? Preventative care, you take care of yourself earlier, you save yourself millions later on in life. That's where this comes from. This book we're reading right here, Poverty, Ethnic Identity, and Healthcare by Vern and Bonnie Bullough. We're at the top of page 193. Kaiser physicians and employees are salaried, but those at higher levels are also eligible to become partners, and as such are eligible to share in profits from the plan. In a 1966 study of the various prepaid group practice plans, it was found that doctors in group practice perform fewer than 1/4 of the number of tonsillectomy, tonsillectomies for each 1,000 enrollees, half of the number of the appendectomies, and only slightly more than half of the hysterectomies done by the fee-for-service physicians. This same trend appeared with the welfare patients enrolled in group practice plans. In 1962, for example, New York City's HIP or HIP undertook to treat welfare recipients, and it was found that its physicians made but 1/4 the number of premium priced home calls and ordered but 1/2 the highly profitable and highly expensive laboratory tests, which fee-for-service solo practitioners were accustomed to require. Under a national health insurance plan, such health maintenance organizations would contract to care for a given number of patients for an annual fee rather than being paid for each service that is rendered. The American Health Maintenance Group would undoubtedly be a more effective capitation plan than the panels used in England, primarily because the primary practitioners in the American plan would not be separated from the collaboration and stimulation of the specialists as they are in England. Thank you all for being here. Peace, Ryan. Hi, it's Harlem. Thank you so much, guys, for your donations. Oh, y'all are so generous. Wow. Thank you again. Darlene, thank you so much. Lewis, thank you so much. I dearly, dearly appreciate you and respect. This book is not the place to decide how any national health plan is financed. Such a topic deserves a study in its own. It still is possible, however, to speculate, if only briefly. An insurance principle in which each worker contributes a portion of his salary, as is done under Social Security, seems a likely possibility. Although payment out of general revenues, which receive a greater share from higher income levels in society, would be easier for the marginal worker to afford, it would be more difficult to get through Congress. Probably some combination of these two sources of financing is most pragmatic suggestion we have to offer. Any long-range planning for health reform also requires that consideration be given to better utilization of health workers. One of the most obvious consequences of any extension of medical care will be the need for more health workers. One of the most obvious consequences of any extension of medical care will be the need for more health workers. One of the easiest ways to solve the problem is to make more effective use of present workers. Laws which bar workers from performing tasks which they can safely and effectively perform need to be reconsidered. Mhm. And perhaps repealed. A simple increase in the number of doctors, if present trends in medicine continue, will not be enough because the present organization of medical schools, with their emphasis on research and specialization, simply accentuates the shortage of physicians. It might well be that financial incentives now being used to encourage research should be reconsidered. Some of the funds might better be spent to educate more doctors of the general practitioner types, as well as nurses and other health workers who can give actual patient care. The suggestion of the Carnegie Foundation that medical education be shortened also has merit. Care must be taken to see that as the healthcare industry expands, there will not be large numbers of people trapped at the bottom of the economic ladder in the no advancement jobs, such as those of nurses, aides, or orderlies. Many such workers are at near poverty levels of income, which in itself is not a healthy phenomenon. More important, however, is the fact that workers who are trapped with no chance for advancement tend over the years to lose interest in their jobs, unless some means can be found to interest them in helping to deliver better health care. All the best laid plans of scholarly investigators and government planners will fail. It is not only that these workers should be paid more, but they should be given in service training and encouraged to work to the full level of their capacity. There were needs to be a democratization of the healthcare team. Another obvious answer seems to be the establishment of the career ladder, that is, on the job training for advancement with entry points at various levels of the career ladder. This would require greater cooperation between colleagues and or colleges or universities and the health care institutions than now exists, but it would follow current trends. Individuals who first begin as health aides might well gain sufficient experience and education to become practical nurses and even registered nurses. Nurses, on the other hand, should extend their role to cover some of the tasks now done by the fast disappearing general practitioner. Pharmacists could be better used to back up the physicians in prescribing drugs, either giving advice on their own or working with the group of physicians to indicate what a drug will or will not do instead of having the physician depend upon the drug salesman or detail man for his information. In effect, the pharmacist, the nurse, and the aide should be better utilized and encouraged to develop and use new skills. And see what I just read, what we call those now are called farm reps or pharmaceutical reps, which go into hospitals and pitch different pharmaceuticals to the doctors to be able to use them. You're talking about big money. I only speak on what I know. Concluding comments. In this book, we have tried to present the healthcare problems of the major ethnic minority groups in perspective. Although poverty is probably the most crucial variable in the genesis of these problems, there are still many subtle and not so subtle forms of discrimination operating in the health field. Unfortunately, discrimination in other aspects of American life also has consequences for health, and in turn, poor health helps to perpetuate the cycle of alienation and poverty. We have tried to emphasize that there are no simple solutions, but that the problems come together into a kind of Gordian knot. There are problem. There are, however, rational and possible steps to take to cut that knot, including 1. Eliminating poverty. 2. Effectively enforcing the laws against discrimination. And 3. Revising our healthcare delivery system to provide total coverage for all of the people. To some, these might seem utopian steps, but until we take effective action against these barriers, America will not fully live up to its potential in the health field. We have now completed Poverty, Ethnic Identity, and Healthcare by Vern and Bonnie Bullough. Thank you and honor to all of you for reading with me. We are in Alaska, completing another book on YouTube. Thank you, YouTube. Highest heart, love, and honor. We did it again. That is the completion. I love you. Gratitude. I love you. We did it again. Completion. Where y'all at? Thank you. Yes. Love and honor. Thank you again, Darlene Harris, for your $40 donation. Gratitude and honor for all that donated throughout the reading. So now it's going to be time to choose another book to read. We did it. We did it. Thank you. We did it. Thank you for breathing with me. Thank you for reading with me. I love y'all. Thank you so much. Highest heart love, guys. So we got a lot from there. We got to see how it's panned out because now we know where we are. We must get health care to everyone. It's so important. We're so behind in doing this in the world. We're going into 2025, guys. It's going to be the new moon is here. So, love and honor, peace. Man, y'all have been so beautiful. Oh, yay! We began this with reading the preface and we completed it. So now we're here. I want to honor all of you for reading books. Everyone that showed up. If you would like to donate, here you go. This is I appreciate all of you. Much honor and love. We get to go back, thanks to YouTube, and read all these books whenever we want. So I will compile it into one file and book reading like the last ones, and you'll be able to just read it. Thank you so much, y'all. Thank you for all the love. Happy New Year. Happy Kwanzaa. Yes. Love to all our ancestors. Love to all our friends and family. We did it again. We did it. Yes, yes, yes. Peace. Y'all have a wonderful new year. We're going into a new time in this world. All right? So, love to all that read with us while we're in LA. All that read with us when we're in Florida. All that are reading with us here in Alaska. Love to all the readers. Man, this is love. Thank you so much. Peace, peace. We did it. We did it again. I love you, Isis.